So good afternoon, everyone. Thank you very much for taking the time out of your busy schedules to join us in this webinar today. So for those of you who were with us last week, welcome back. My name is Iracema Leroi. I'm an Associate Professor of Geriatric Psychiatry at the Global Brain Health Institute, Trinity College, Dublin. And I'm one of the directors of the Dementia Academy, which aims to support the knowledge and practice of frontline clinicians. So the COVID-19 pandemic is having far-reaching impact on all of us and how we're practicing, particularly in the way we're supporting older people with dementia and their care partners. But while adapting to the current reality, we have to do so very thoughtfully and carefully. And so we're trying to gather and share as much evidence and experience as we can in order to do that better. And we really strive to ensure that the information we share is accurate, practical, and meaningful. So last week we divided our questions into themes: clinical care, adapted working for memory clinics or dementia services, and complex decision-making. And based on the feedback, this approach seemed to work quite well. So we'll do the same thing this week. We'll answer a few questions that came in from delegates last week about clinical care, adapted working, and complex decision-making. And I'll pose questions to our panelists in turn. And as you saw from the leader slide, if anybody has questions, please post them in the chat. If we have time at the end, we'll address them. But otherwise, we will put answers either next week's Academy or type answers onto the website. And all the information will be found that we're referring to will be found in our resource hub on the Dementia Academy website. So just one caveat that everything that our panelists will be saying are their own views and not the views of the institutions that the panelists work for. So I'd just like to introduce everybody. The first person is Dr. Karen Harrison-Denning, who is Head of Research and Publications at Dementia UK. Karen is a dementia, an Admiral nurse who's been working with families of people with dementia for many years.
Good afternoon.
Next, we have Diana Burgui, medical social worker at the Memory Clinic at the Mercer's Institute for Successful Aging, St. James's Hospital, Dublin.
Hello, everybody. Good afternoon.
Dr. Joseph Kane, who is a clinical academic in geriatric psychiatry at Queen's University, Belfast.
Hello, everybody.
Dr. Gregor Russell, consultant psychiatrist at Bradford District NHS Care Trust.
Hello, everyone.
And finally, Dr. Clara Domínguez Vivero, who is an Atlantic Fellow for Equity in Brain Health at the Global Brain Health Institute, Trinity College, Dublin. And her job is at the end to bring together in the last 15 minutes new information, scientific publications, and web links, all related to COVID-19 and dementia. And so she's building on the collection that she started from last week, so you can access those at any time. And she'll be walking us through what she has found in the past. So we're going to jump right in. So the first question I have is for Gregor. We discussed some of the potential risks of cholinesterase inhibitors in people with dementia, citing concerns around cardiac risk and potential worsening of hypoxemia, because cardiac arrhythmias and, of course, hypoxemia have been seen in people with COVID-19. So the question is, in view of this, would you use cholinesterase inhibitors as a frontline medication for behavioral disturbance in dementia instead of antipsychotics?
I suppose I'd preface any question about the use of medication to manage behavioural and psychological symptoms in dementia by saying nothing we have is particularly effective and everything we use has potential hazards. And that I would therefore say go back and revisit. If you think you need to use medication, go back and revisit the formulation you have and check, do you really need to use medication? Have you considered what other factors may be manageable here? Have you looked at overall physical health? Have you considered all the potential could be a delirium, and there may be options there? Have you looked at the environment? Have you looked at the relationships and the way people are interacting with the person? Because the chances are, even if you think you've done that, there's still going to be more value in finding a solution there than going to medication. But of course, there are times when you do that and you still need to look at medication. And if you're picking between them, then you want something that's going to be relatively, the side effects are going to be relatively manageable and not make the situation worse, and hopefully it's going to work. Now, cholinesterase inhibitors, there's a number of drawbacks in that regard. Introducing them, we have to introduce it at a low dose and build the dose up, and the gap between titration points can be up to a month. So if you're looking for something that's going to work in the short term and deal with the here and now, that's not necessarily going to be helpful. There's also, I feel from my own use of cholinesterase inhibitors in practice over a number of years, I don't think they are, I know NICE would suggest them as an option for behavioural symptoms. I've never found them to be very effective. And the other thing is, the chances are if the person has got Alzheimer's disease, it's likely they will already be on cholinesterase inhibitors by this point, or may have been considered for them and they've been deemed not suitable. So I think overall it's unlikely the cholinesterase inhibitors are going to be a solution here. One option may be memantine, and certainly myself, and looking at the practice of my colleagues, we would use memantine fairly regularly for this option. It still shares the drawback that you have to titrate the dose up over a period of time, so it's not going to be the solution for behaviours which are very challenging and risky immediately, but it may be something that's worth considering if you've got slightly longer, that you can wait for the effect to build up. And also, it's relatively well tolerated. There would be some concerns about making sure a person's renal function is sufficient. And also, there are a group of people who seem to develop a sort of delirium-like picture with it, where they become more confused, hallucinate, and become irritable. And given that that can be a presenting symptom of COVID, you'd have to be a bit cautious there. But overall, I would prefer memantine over either cholinesterase inhibitors or antipsychotics for this option.
Thanks very much, Gregor. That's really clear. Just to follow on that question, if for some reason you did have to start a cholinesterase inhibitor now and possibly didn't have the support of the memory clinic because services have been closed, how might you manage that situation potentially with the support of the GP?
Yeah, so this is something we are coming up with as we try to bring memory services back up and running again, but doing it by remote means, often by telephone. It's a challenge. So normally we would want to do some sort of assessments of cardiac safety for a cholinesterase inhibitor before we prescribe. It's not necessary that everyone has to have an ECG, but we would at least want to examine their past history of cardiovascular disorders, look at their existing medication, and do a pulse check. And we're not going to be able to do a pulse check either by video technology or down the phone. Now, I know some colleagues that have asked a relative to do the pulse check on their behalf. So I've come across that. I've not done that myself, but I've seen it happen. I've heard of people doing it. I think it comes back to you're looking at the overall, it's the same decision making under any prescribing. So the risk of the exposure to the treatment versus the potential benefits of it. And in this circumstance, the risks are maybe a little bit higher because we're not able to do the close monitoring. And the benefits are still there at the same level. So would this person need the medication now? These are not disease-modifying drugs. So if the person were to delay starting them by a month or two, maybe we can see people then. Maybe it'd be better to hold off and start then. Of course, we don't know if it is going to be a month or two yet, but I think largely I would be taking a view that because hopefully the person will be put back in the same place they would have been when we do get to see them, I'd probably hold off prescribing a cholinesterase inhibitor just now, or I might consider memantine. If the person would meet the criteria under NICE guidance, then this is one circumstance where I might move a memantine ahead of, for example, donepezil in prescribing order.
Super, thanks, Greg. That's great. Joe, I'm going to ask you the next question. So, of course, as everybody knows, long-term care facilities are extremely high-risk settings for poor outcomes for COVID-19, owing both to the advanced age and the frequent chronic underlying health conditions of the residents, and also the movement of healthcare personnel among facilities within a region, although that's now really being stopped based on the new guidance. But questions are being asked about how many COVID-related deaths in care homes are people with dementia? And related to that are how many COVID-related deaths in hospital are people with dementia? Have you found any information about that?
Thank you. Well, it's a very important question, but both of the questions are very complex ones, and they're complex for a number of reasons. When we talk about care homes, we know that there's been a lot of criticism towards certain organisations and jurisdictions about testing in care homes, and we need to bear that in mind when we look at any data as to how many patients in care homes are actually being tested. Secondly, we know that in care homes there's a very high proportion of patients who have dementia, but have never formally been diagnosed with dementia. And again, that will not be reflected in the statistics. Thirdly, we have to bear in mind that there's huge variation in both practice and demographics between different care homes, both nationally and internationally, and that influences the way we address this question. What we can do, the type of data that we can rely on is to look at the proportion of patients within care homes that have dementia. And if we assume that all residents within a care home are subject to the same level of risk from COVID, which isn't an unreasonable assumption, we can suggest that the proportion of people in care homes that are dying with dementia is likely to be somewhere between 60 and 80% of those care home deaths. However, we do know that there are very unique challenges that arise with managing dementia in a care home, and particularly with respect to social distancing. And so in all likelihood, the chances are that a higher proportion than 80% are represented by those individuals with dementia. A lot of the interesting papers that have been published over the past few weeks in this type of area have been related to the very well publicized cases in Washington state. The papers that I've seen haven't really provided specific information on the proportion of the patients that have dementia in those cohorts. What is interesting is that it provides interesting insight into how many of those patients have symptoms, how many of them are getting COVID, and how many of them are having to go to hospital. So I was very interested to find out that it was only just over half of patients in the Washington care home actually had symptoms. So it really underlines the importance of testing in care homes, even in those individuals that aren't demonstrating symptoms. In those that did test positive, around 25 to 35% did go to hospital, and so did die. Some of those patients were in hospital, some of those died in care home, but again, it underlines the real risk of mortality in individuals in care homes. So it really shows us the importance of testing, but it also emphasizes the importance of infection control. When it comes to the hospital-related deaths in people with dementia, again, this is very difficult to answer because of huge variation in reporting practices. Before COVID, there's an often quoted statistic that 6% of all individuals with dementia at any given time are in a hospital. But COVID has changed clinical practice a great deal, and we know that the thresholds for admitting people to hospital have changed considerably. Perhaps patients with dementia that would normally have been admitted to hospital under these circumstances are not being admitted because of the risk of COVID. A paper soon to be released in the UK has indicated that around 10 to 15% of 16,000 patients in hospital testing positive for COVID had a dementia diagnosis. However, we know that this type of data is really unreliable, that when it comes to hospital recording of comorbidities, that it can be very inconsistent, and that extends to death certification as well. So I would imagine that 10 to 15% is probably an underestimate, both of the patients in hospital with dementia and in patients dying with dementia. I really don't think that we'll be able to get any greater certainty in these figures until later on down the line. So we have to be very careful by the way we review the statistics. The hope is that time will tell, give us a bit more information about factors that protect people and factors that put people at risk.
Thanks, Joe. That's extremely helpful. Thank you for doing the hard work in digging up those stats. Diane, I'm going to switch a little bit now. I'm going to ask you the question about carers, and the question is, how can we better support solo care partners at home with their mental health who now find themselves in a very difficult situation with no respite? And just before you answer that, I just want to share with you some data that have come out of Alzheimer's Society Ireland survey led by Dr. Bernadette Robb from their stakeholders. And what it revealed is that the three greatest challenges for care partners and people living with dementia are, first of all, loneliness and isolation, lack of routine and boredom, anxiety, fear, and carer stress. So really no surprise there. And they also found that 95% of community champions felt that people with dementia in the community required practical emotional support or both during this COVID period. So if you can just give us a little bit of insight as to how to manage that situation.
I think the first thing to say, and I'm giving myself a little license here, I was reading yesterday an article written by a researcher in Barcelona in Spain who has noticed the huge similarities between the bubonic plague that befell the world about 1,500 years ago. And at that time, a writer says that caregivers of the era dropped from exhaustion because they were unable to rest and were constantly suffering. And because of that, everyone felt more sorry for them than for the sick. 1,500 years after, we have a similar situation, but only similar. What can we do now that couldn't be done then? As you were saying, practical and emotional support. Carers are terrified that, for example, they may fall sick and what is going to happen to the person I'm looking for. Practically, people need information. And yes, there is a lot of information out there, but it's not reaching everybody, especially people who are not that internet savvy. So that information has to come in ways that they can relate to, and that is mostly going to be the phone call. The telephone is going to be our main way there. People need to know that they can ring to talk and that somebody is going to listen there. They need to be able to vent, and practically support with running errands, collecting a prescription, walking a dog. Those things that they were able to do and they are not able to do now. And it's taken, shaving off little bits of busyness that could overwhelm them. Emotionally, regular telephone contact. That very same survey that you were saying was saying that 3 in 4 people interviewed felt that was really the intervention that they welcome most, that they were expecting the call every day. And that could be how are you, how have things been today? And that is most helpful for people at the minute. There's another thing that could be done is facilitation of peer support, a Zoom, a FaceTime meeting between peers, or a body group system, even a WhatsApp group, so that people can talk to other people who are in similar circumstances. And it feels a little bit less lonely in the caregiver world. And then activities, fun and engaging where possible. And on this, I can point you to an activity planner that's Dementia Services and Information Development Center, along with the Alzheimer Society here and the National Dementia Office, have put together with 3 weeks of a good balance of activity. And that will be shared in the website later for people to access it. And one piece of advice I would have for nurses to tell carers, or for carers, is that there is no time. We don't have time. We make time. And then you may say, you make time. You have to make time. 5 minutes is time. 10 minutes is time. And it's okay to say, these 5 minutes, I'm putting myself first. I'm going to close my eyes and I'm going to breathe. And that is what we need to remind carers, to be able to continue, because we are in this for a long run. This is not a sprint. This is a little marathon we're running.
Diana, that's an extremely good advice. So I think that's a real take-home message. This is not a sprint, it's a marathon. So we really need to put things in place to support people. So I think, just a follow-up question on that note, do you think that there's a role specifically for memory clinics to do more proactively, to contact families for checkups and perhaps providing some of the support?
I think there is, definitely, and I would advocate for the proactive approach. I suppose there are memory assessment services and memory clinics. Memory assessment services go from the assessment to the diagnosis, and then they follow up and they signpost, they provide the post-diagnostic support, and memory clinics finish at the diagnostic point of view and pass the care on to the referrer or the community. I do believe that we are not at liberty at the moment of passing care to anybody else. We have known a patient very well. We need to continue with that care. And the way to do it, especially in these times, is with a proactive approach. Make people feel that they are valued and they are supported, because you are making the phone call through them. There are many people these days who need to be given that permission to join a new group or a new initiative, even if online, and even how are you doing? I was thinking about you. how are you coping? How is your mom doing through this? Could be really, really helpful. Many people as well feel that they are imposing on health services. I get emails saying, if this doesn't suit, please don't reply to me. I believe that you are busy with other things. And I don't understand why people do that, but it doesn't matter if I understand this. We need to allow them to feel, no, you are the person I'm working for. You don't care about anybody else. People are delaying presentations to hospitals. People are not going to GPs, to emergency departments. People are delaying presentations when they've had a stroke. And the stroke is more likely to kill you or to leave, really, really bad consequences than COVID at the minute. Tele-support is something we are going to have to start to do. We had a model of a clinic where face-to-face was okay, and that's what we were doing. Older people now and for a long time are not going to want to come to our clinics because they are going to be terrified. So we need to start ringing them. We need to start being creative and training ourselves in how to do it. How do you do a tele-support properly? How do you start the conversation? How do you interview? A conversation with a purpose. This is not a questionnaire. This is not a survey. What you need is to know what you want to ask, fit it in a conversation, summarize, come to an agreement, and help the patients get the best of us remotely.
Super, Diana. That's extremely helpful. Lots of important points there. Thank you. I'm going to switch now to Joe. So it appears that there may be neurological complications related to COVID-19. Would you please discuss some of these and a potential relationship to worsening of dementia or even increasing the risk of developing dementia in the future?
Thank you. That has been one of the more interesting for me, one of the more interesting fields that has emerged over the past few weeks has been the emergence of reports specifically with respect to neurological symptoms. Probably one of the key papers which I would refer people to is the one published in the New England Journal of Medicine relating to the initial outbreak in Wuhan. And it reports that over a third of patients that tested positive for COVID-19 had neurological symptoms of some type. And again, this was a good study. This was a kind of every single patient being systematically appraised by a neurologist. And it presented some really interesting features. Some of them are fairly well documented and fairly well publicized. So the loss of taste, the loss of sense of smell have been widely reported in the media. But there's a huge spectrum of levels of neurological symptoms that have been reported. In fact, lots of patients saw dizziness, some of them saw falls, muscle weakness. And in fact, in 6% of patients that tested positive for COVID-19, they actually had strokes, seemingly as a consequence or at least comorbid with COVID-19. Interestingly as well, when you look at this cohort and lots of the papers that come out of China when it comes to the symptoms and the characteristics of that population, you'll note that it's quite a younger population in comparison both with our community and with our hospital populations. So it's not unreasonable to think that in over 65s and over 70s, where we know the vulnerable brain, the brain is a little bit more vulnerable, that there could be even greater prevalence of neurological symptoms and stroke in particular. In terms of the mechanisms for this, this is again a really interesting area. We know that coronaviruses, at least the SARS and the initial coronavirus outbreak, did demonstrate the ability to travel from the respiratory tract, where we see the cough and the fever, into the cerebrospinal fluid and into the brain. So we do see good evidence of that. Now, that hasn't been yet demonstrated in COVID-19, but hopefully we'll start to see some more studies in the next few months looking at that. So these neurological symptoms might be a consequence of the virus itself, or it might be a consequence of the body's response to the virus. And what is increasingly apparent, irrespective of the mechanisms that underpin this, is the fact that there's a real evolving opinion on how COVID-19 presents, particularly in older people. It's becoming increasingly apparent that we need to look beyond fever, beyond cough and be on the lookout for what's currently known as atypical presentations, but may not be that atypical when we look at older populations. With respect to dementia risks, again, I think it's a little too early to say whether or not COVID-19 has a direct relationship with dementia, but there are a number of facets of the presentation of COVID that we know pose risk for dementia, and significant risk at that. So we've already discussed cerebrovascular disease. We know that that is a significant risk factor for the development of dementia. There are patients who are developing different dementia subtypes in their brains with no symptoms whatsoever. And frequently it takes something like a fall or a hospital admission or a stroke to precipitate those clinical symptoms and create that person's first presentation with services. The second risk factor was touched on by a question from Tim, and that's delirium. We know delirium is a massively significant risk factor when it comes to dementia. It can be some people's first presentation, and we're starting to see more and more information coming out about delirium presentations of COVID-19. These have thus far just been case histories, and again, we know that delirium is not well documented either in hospital notes or in death certification, but it's something that people like the British Geriatric Society have turned their attention towards, and the Royal College of Psychiatrists in the UK have been asking for the submission of any individual case reports of patients who have delirium and therefore are at greater risk of dementia. So if you see somebody whose dementia appears to have acutely deteriorated, if you see someone who has cognitive symptoms for the first time, you should be thinking about delirium. You should be thinking certainly about COVID-19. And as usual, you should be thinking about underlying dementia. When it comes to characterizing that risk in terms of statistically, I think we're going to have to wait a wee while for that to be fully uncovered.
Thank you, Joe. That was extremely comprehensive. Really appreciate it. We're going to shift to the next theme. So we've been talking about the clinical issues. Now I just want to touch on adapting clinical services for people with memory impairment and dementia. And Karen, I'm going to ask you the first question, which is a little bit of a tricky one, but we're getting reports that people with dementia are being sent home from their acute hospital admission following an infection of COVID-19 without adequate home and community supports in place. Can you give us a bit of guidance about how we might manage that?
I think you're right, it is a tricky one. I think that in ordinary circumstances, when we're not in the throes of a pandemic, people with dementia being discharged from acute hospitals don't always get a fair crack of the whip, and there is accusation that they might not receive services similar to those that are not cognitively impaired. There is guidance that we have from NICE and from the NHS that discusses not just being discharged, but the processes of going into hospital, should that be the case for people with dementia, and indicating what people can expect, what families can expect. But I think that when we're actually looking at these situations through the lens of COVID, it really is not straightforward. And the concern is that not just that people with dementia, upon being discharged from hospital, are being provided with care packages to help them resume life as it was beforehand, but there is a concern that people with dementia are probably being admitted into care homes inappropriately because it's more difficult to discharge them back home, particularly if they're in a situation where they live alone. But there is still guidance from NICE in what people can expect, and there is indeed a 24-hour telephone helpline organised by the NHS to help people through discharge processes. What we are seeing from quite a few acute hospitals is that they have rapid discharge teams that are expediting people out of hospital for whatever reason, whether that is from a suspected COVID infection or from any other condition, like we heard about people avoiding going into hospitals following stroke, which indeed my mother has done over the last week. But what we are seeing is that these rapid discharge care teams are coming out within the first 24 hours of discharge and enabling step-down services. We're hearing patchy reports where this is not always available, and we're probably tending to see this in larger cities, probably where such resources are being stretched more so than in more rural areas. If this is a case for a person with dementia that you're caring for, then I would advocate that you ensure that you negotiate with the discharging hospital what is available in that area to make the best possible decisions and care packages available for the person with dementia that you care for. Or indeed, again, as Diana was saying, you know, let's all use the telephone, let's contact the services that are still available. And I draw your attention to the Admiral Nurse Dementia Helpline, who can probably specifically look at what resources are available in certain areas to help you through this particular dilemma.
Thank you very much, Karen. That's helpful. Can I just, sorry, that's my email. Can I just check that whether the helpline is available? Sorry, to which countries is it available? Is it beyond England as well?
The helpline, we take calls from whoever, so we do collect quite a few international calls, but it's predominantly UK based. But obviously we can't advise somebody that telephones from Brazil what particular services are there, but nevertheless, a lot of information relating to dementia and caring for somebody with dementia is very transferable.
Yeah, and that's available 24/7, is it?
It's available. We now, it's not 24 hours a day because we actually evaluated what calls we do get out of hours, and they don't tend to be that many. But we have now extended it since COVID to include all bank holidays apart from Christmas Day, so 365 days a year, or 364.
Right. And the link will, of course, will be on our website as well. So that's great. The next question is for Joe. Last week we talked about memory clinics starting to work remotely, and we had a few specific questions about teleneuropsychology, in other words, remote cognitive testing. What guidance is out there, and should we be engaging in teleneuropsychology?
Thank you. And teleneuropsychology is something which has been explored briefly in little pockets for a number of years, but it has really been the COVID pandemic which has really driven forward practice and really encouraged different teams to try and explore this. I couldn't find a great deal of dementia-specific evidence or guidelines on this. There are guidelines, but most of them actually highlight the difficulties in using telepsychology in over 70s for a number of reasons. Interestingly, Public Health England have actually advised against the use of telepsychology in any individual over the age of 70. And quite strongly so. Obviously, that's very arbitrary. Obviously, that preceded the COVID epidemic, but the Royal College of Psychiatrists in the UK have recognised more recently that these are unprecedented times and exceptions to these rules must exist. The clearest guidelines that I've come across have been from the Royal College of Psychiatrists in the UK and in the American Psychological Association guidelines. And we'll put the links to both of those up on the website. The American Psychological Association have also provided a free course that you can do online. We'll put the link up to that as well. There are a few themes that arise quite consistently in these guidelines. And the first of them is to make sure that you're bearing in mind the inherent limitations posed by remote assessment. And that often relates to the fact that a lot of our cognitive tests simply have not been validated through this method, and that you as a practitioner must be familiarising yourself and taking into account the fact that you can't attach the same type of significance in a test that has not been validated. Your standard of care must not be compromised in any way by the medium. And across the board, the guidelines state that where teleconsultation exists and where it produces any doubt when it comes to diagnosis or management plan, that you must follow that up with a face-to-face call. So it's very much being seen as an adjunct rather as a replacement in many circumstances. Another point raised is one of confidentiality. I thought this was quite interesting in the context of sometimes what we see in the clinic when it comes to neuropsychological testing. So if you have somebody in the room with your patient, often sometimes it's a carer who is in the room with a patient, they can deliberately or not deliberately try to be helpful and actually coach the patient. So they're trying to encourage their loved one, they're trying to support them, but what it actually means is that the patient's performance in that neuropsychological test is inflated. And that can be 10 times more difficult when you're not in the room. The patient's caregiver might be behind the screen, they might be out of your view. It's something that you need to check. And you also need to check as well when it comes to confidentiality. You need to check exactly who is in the room and whether or not the patient has provided their consent for them to be in the room and listening in your consultation. Finally, just a point again about neuropsychological tests is that they're quite explicit and that the practitioners need to ensure the integrity of the test when it's being delivered. And I think this poses us quite a lot of problems in terms of demonstrating the absence of evidence for a lot of our day-to-day neuropsychological tests. I know that Gregor's going to talk a little bit about the MOCA, but we can't have the same kind of certainty when it comes to the results of these tests as we can when we're delivered face-to-face. So I think this is challenged quite a lot by the emergence of telepsychology, and it highlights an area that we really need to do a bit more research in. Nevertheless, in the meantime, please visit the links that we're going to put on the website because they are quite informative and practically helpful.
Thanks, Joe. I think that's all really important points, and those caveats I think are very important. But at the same time, we have the practical reality in some cases of having to do some degree of testing, particularly if people are going to be reluctant to come to the clinic as we start opening up, or reluctant to have people visit them at home. So on that basis, there have been a lot of questions about the use of the online MOCA or other cognitive screens. Gregor, can you make a couple of comments in relation to the online MOCA and what we should be thinking about here, keeping in mind what we've just heard from Joe?
Yeah, so there's so the MOCA, I presume most people will be familiar with it. It's a 30-point kind of broad spectrum bedside cognitive test, which gives information on a range of domains of cognitive functioning. Can be administered relatively quickly in 10 or 15 minutes or so by someone that doesn't have necessarily have to have a large degree of background in administering tests. A caveat would be that there is a requirement coming in with the MOCA to have undergone a degree of online training and to pay a fee to access it. But that's not yet in place. I think you can still register to say you're going to do the training as long as you do it by, I think it's October. There's resources on the website which will give the details on that. So with the MOCA, there's some options, and it depends what you have available to carry out the consultation. So if you have got video consultation available, and I think that will probably increasingly become possible, as I know there are a number of areas which are exploring this, and in our own area where there is a video medicine service going to be up and running shortly for frail elderly people in the community. So it may be possible to do the normal MOCA with being able to use the video technology so that the person can see what they're doing and you can see what they're doing. I think people will still need to get used to that to some degree, and it won't be just as straightforward, but it would possibly be able to keep the broad spectrum of the MOCA of all the domains covered if you were able to do it that way. Another option is there is a validated MOCA for people with visual impairment, a blind version. And that really is the MOCA, but with the items you need to see taken out. So it's scored out to 22. The cutoff point's different. You're looking for a normal score being taken as 19 or above. So that would be possible to do on a telephone basis. Again, there's caveats. You can't see if the person's being coached or prompted by family members when they're doing it. But it's certainly an option available. and it's would be one that is maybe a bit like there's a mini mental state blind as well, which is another alternative which can be done by telephone means. There's also an abbreviated mock-up now available. It's been validated, but I believe not yet published, which is a shorter test, only 15 items, and can be done more quickly for someone that maybe is finding it hard to sustain the concentration to do a telephone test, which is lasting for, still maybe 10 or 15 minutes. So those are all variations of the mock-up that might be available and might be suitable to consider depending on your own circumstances. I would say that whatever you use, you always have to bear in mind what's the purpose of doing the cognitive test and what information are you hoping it will provide you with. And always bear in mind that when we're seeing people even face-to-face in the same room, we're always having to bring a degree of interpretation to what's being, to what we're seeing. So I work in Bradford. Bradford is a very high proportion of the population where English is not the first language, and where we're using tests that are probably not validated for use in the language they're going to be doing it in. We're using interpreters. That adds a degree of complication too, because the interpreter isn't trained in giving cognitive tests. So in everyday practice, we're used to taking the results we see with a pinch of salt, with having to apply a degree of interpretation and look beyond just the simple number we get at the end of it, and more at how did someone actually engage with it? How did they perform in different aspects of the test? And we can still do that with either telephone testing or perhaps testing through the video. We wouldn't, I hope, just be guided by the simple number we got at the end of it. Would be applying a degree of common sense and applying our diagnostic skills in other ways. It's more information. We can make use of it, but we're always taking it alongside the clinical history that we're getting and the informant history that we hopefully will have access to. And we're taking all that information together and not relying on one simple dimension. So I think there is a place for cognitive testing, but we've always got to make sure it stays in that place and not allow it to be the thing that's guiding us over and above all the other bits of information we have.
Thanks very much, Gregor. And I think I'm just going to add to that a little bit, because this question is very common and people are really struggling with it at the moment. And that's the issue, again, partly related to the over 70s, but that aging-related hearing, vision, and dual sensory loss is extremely prevalent in people with dementia, so upwards of 80-85%. And as soon as you start bringing sensory impairment, you lose even more validity of your test. And with this point in mind, I just want to draw people's attention to a very nice article that was written by Walter Wittich and Natalie Phillips from Montreal. They're co-developers of the MOCA, and both of them are international researchers in hearing and vision impairment in dementia. And they've put together some important guidance with regard to this particular issue. And next week, we will have a recorded video link interview by Walter and Natalie, explaining some of the issues and the caveats in using the online remote version of the MOCA in the context of hearing and vision impairment. And I just really strongly encourage people to be aware of that. And of course, we'll post their article as well. So please see if you can track that down. Okay, moving along here. Diana, the next question's for you. Some families are now at the stage where they're finding it difficult to cope in managing the care of a person with dementia at home in restricted environments. And in normal circumstances, they would consider admission to a care facility. They're now frightened to do so. And also several facilities are not accepting new residents. What kind of guidance is there for families in this situation?
I think that the first thing that I question in the sentence itself is who is they? Because what I hear throughout is that we cannot achieve the golden standard with COVID, but we still need to remember what it is, whether it is the caveats with the MOCA and the remote testing, or people being discharged from hospitals without proper care planning and without the enough support. So I'd be worried that people or caregivers, families are going to say, I'm completely overwhelmed. He or she must go to a nursing home. Whose decision is this? That's the first thing that we need to question. This needs proper care planning. And anybody transferring to a nursing home these days, I would almost put it under the condition that it is temporary and that once that circumstances, knowing that transfer to nursing home care, even transfer to respite, has a deleterious effect on the older person, which from mobility, from cognition, sense of self, continence, I've seen it throughout. But what I suppose advise at this moment is hang in there, hold tight. Do not make a life-changing decision like transfer to nursing home care because of COVID. And again, that's where we go to the proactive. If you're struggling, look for help. Talk it through with somebody that either an Alzheimer's Society nurse, a primary care doctor, or a primary care team, and they'll ask you, what's your day like? You talk through what your day's like, what you do, what you don't do, what causes struggle, and see if they can help you continue. And realize that this is a time for survival. This is not a time for self-realization. And on this point, I'll bring Maslow pyramid. We are on the orange at the minute. I don't know if you can see it well, but it will be there for everybody. I mean, we all aim, to self-actualization, self-esteem, my respect, my everything. This is about safety and security and about survival at the minute. So what I'd say to nurses who are getting the call saying, I just cannot cope anymore, is see what's behind that and see if you can support those families in continuing going, because this is not the right time. And not that ever, I've always said that transfer to nursing home is almost the lesser of two evils. It is not, it's a life-changing decision. And mortality in nursing homes, and there will be an article of longitudinal study, is about, the survival is about 2.2 years. So the best that my nursing colleagues could do is assess the need, agree plans, find tweaks and interventions, involve the rest of the primary care team, and make decisions. If the decision is yes, there is nursing home care as high as you can, as the gold standard, because yes, there are places in nursing homes. And in fact, at the minute in Ireland that I know, the process has been changed. There is an assessment of need and a financial assessment. The assessment of need is being done and the financial assessment is being done after. But this shouldn't be a case of a main carer falling ill or being taken to hospital. This should be for an emergency where the main carer is not there. So that's the best advice that I can give. Do not rush into these decisions, not at this time.
Thank you very much, Diana. And just to continue the theme of complex decision-making, because there are no easy answers, I'm going to pose the last question to Karen before we turn to Clara. Karen, there are reports of the rise in the number of DNR, do not resuscitate orders for older people being admitted to hospital, particularly because they're often unaccompanied by families. Can you provide some guidance on how this can be managed and what families can do to ensure their views and the views of the person with dementia are respected?
Yes, it is a tricky question, and it is the last one. I think that this has been sort of emerging, its ugly head's been emerging for some time, and it's not just hospitals that are being accused of blanket DNARs as soon as somebody with dementia is admitted. We've actually seen instances where GPs have written out to everybody over a certain age on their practice, even to the point where some have crassly sent out a form for them to fill in and sign, which is a DNAR form. What we're talking about is what's under the umbrella of advanced care planning, and it's often people with dementia, as probably many of the British population, tend not to talk about death and dying until it actually faces them head on. And death and dying is facing a lot of people head on at the moment with COVID-19. In any ideal situation, it would be good for families to have these conversations prior to any pressing situations such as this. But that having been said, these difficult conversations can still be held. And so a person's wishes and preferences can be taken into account. It's not just all about whether to apply CPR or not. There's much, much more to be considered. And as Diana was saying, wishes and preferences about whether to go into a care home or not. our backs are against the wall to some degree. So some of these conversations, difficult as they are, we do need to make them. And some of the practices that I would normally promote in terms of taking time, involving trusted professional to support you in doing this, may not be available for you at this moment, but there are resources. And again, I would point you to the Dementia UK website, and we can send the link to this, but we have produced guidance which has been co-produced by people with dementia and families in how to have these difficult conversations, what to think about, what to plan for. And I would advocate that any family or anybody that's caring for somebody with dementia goes and actually looks at some of the resources that are available, and rather wait until somebody tries to apply a blanket DNAR to you or to your loved one. Plan ahead yourselves and start to think about these things before they're posed to you in extremely distressing situations and difficult times. I'll hand the resources so that they're available to the Dementia Academy website.
Thanks very much, Karen. And also, just to say that this links in with the discussion you had last week about advanced care directives in these circumstances. And we've also posted a specific recorded video clip about this issue on the Dementia Academy. So that's extremely helpful. And now we're going to turn for the last few minutes to Clara, who's going to share her screen and give the latest roundup of information on dementia and COVID-19, both public-facing and also from the medical and scientific literature. So over to you, Clara.
Thank you, Iracema. Hello, everyone. Can you all see the screen?
Yes.
Okay, perfect. So first of all, regarding clinical care, I went first to look for resources on neurologic manifestations of COVID-19. There's this paper, I think it has been already mentioned during the webinar, from Wuhan in China, very interesting. And then also this scoping review, not only on the neurologic manifestations, but also on the particularities of neurologic patients dealing with COVID-19. So it has a double interest. Then we are also wondering if if SARS-CoV-2 can infect the CNS and how does it do it. So these two papers are very interesting. This one, the one in the bottom, you can see on the right, the image of COVID-19 particles inside a neuron. So it can, and it's a case of delirium, and viral particles were found in the frontal lobes. So it's quite interesting. And then finally, this kind of review of the different ways that the virus and the disease can affect the central nervous system and cause neurologic complications. On another different kind of clinical care approach, some useful resources for older patients. This review on 15 smartphone apps that can be useful for older patients is very focused on the American scenario, but I think it can be used as a model to look for resources for them here as well. And this Canadian geriatrics recommendations, I think, is very brief and very simple about what do they really need to know. Regarding drug management, because we get a lot of questions on this topic, I have to say that it's quite difficult to find specific information about dementia treatment and COVID-19, but I found this new two resources for drug management that I think can be useful regarding interactions and how to take decisions regarding chronic treatments for patients. And then on adapting services, I think this online resource is very, very interesting. It's a great guideline on how to adapt a memory clinic during the pandemic from the Australian Dementia Network. I think it goes through everything that is worrying us. So how to adapt our service, what to prioritize, how to go through neuropsych testing remotely, when is it correct to do it and when it is not, how to provide support as well. So for example, they have this very interesting table on neuropsychology test list options, which ones have been validated for telehealth, which ones have not been formally validated but have been used. So I think it's a very interesting resource. Then again, the Journal of the American Geriatric Society keeps providing a lot of interesting materials, such as this paper on examining older adult cognitive status in the time of COVID-19. And then I think these other two resources were already mentioned as well, is the guidelines for the practice of telepsychology from the American Psychological Association and the Division of Neuropsychology of the British Psychological Society. They also have guidelines and recommendations on telemedicine regarding psychological testing, but also psychological support. So it's very interesting. And what's the experience in other memory clinics? We have a report from a French one, the impact of the COVID-19 outbreak on the clinical and research activities of memory clinics. And then also this report on how a Chinese mental health service dealt with the COVID-19 outbreak. More on rehabilitation services, and these two, a guideline and a report on how to adapt adult social care and nursing homes to this new situation. And I think they are very thorough, quite long, the first one, but it's very interesting. In complex decisions field, I think I've already talked last week about the Swiss Medical Weekly, but they seem to have very good materials on difficult decisions. This is about frailty, age, comorbidity, and how to allocate resources when they are scarce. But I also wanted to pinpoint these two documents, the one of Inclusion Europe on how to prevent harm to people with intellectual disabilities and their families. And then this document from the United Nations on the human rights of persons with disabilities that during this situation. Regarding how do we keep going with research during this time, well, we have very interesting news on epidemiology, so research is being made. This paper is the largest detailed description of COVID-19 in Europe, and it has very interesting information also regarding dementia. Actually, they talk about the risk associated with dementia regarding COVID-19. This paper in the top, it's about neurological research in the ICU and in COVID-19 patients. And we also have some results, hopeful results with some treatments for COVID. And there has been released also these guidelines from the European Commission on how to undergo clinical trials during the pandemic. And finally, and just to finish and wrap up, the online resources. So from a medical point of view, I think the Neurocritical Care Society website is very interesting. They have also a lot of resources regarding ethics and rationing of medical services. As I use it so much, I thought I should recommend the Swiss Medical Weekly website. Again, a lot of materials regarding palliative care and ethics in this situation. The HSE clinical guidance and evidence, very complete, constantly updated repository of guidelines and clinical evidence about all aspects. Then if people feel more like listening to a podcast or watching a webinar, we have this University of Minnesota website that it's full of resources, and then also the YouTube channel of Frontiers. I highly recommend these two videos, Can the Brain Be Infected? And Is There a Link with Aging? This one is particularly interesting. And finally, for patients and caregivers, I should recommend the Ideal Project website with a lot of useful tips during the coronavirus outbreak. And then the Penn Memory Center website, although it's not very visually appealing in my opinion, has a lot of good advice, like anxiety busting tools for caregivers, activity ideas, as Diana mentioned from other resources, a sample daily routine that they can go with. And then I really like that for the first time I found different resources for Alzheimer's disease, frontotemporal degeneration, and Lewy body dementia, because we know they are very different. So I thought this was interesting and should be remarked. And just to finish and wrap up, we should think what disability means during this time, because I think it's very important. Thank you very much.
Thank you very much, Clara. It was absolutely masterful. And for those of us who are lying awake at night worrying about how to support our patients and move forward, I think we just need to click into your wonderful collection for our bedtime reading. Thank you so much. So I think I'm going to wrap up because we're coming to time. So I just want to thank everybody. Thank you, Sarah, very much for hosting and organizing us. And Joe, Gregor, Karen, Diana, and Clara. And of course, Hugh. It was kept us all in line. We'd be very grateful for people's feedback to know whether we are hitting the right questions, answering things in the way that people find helpful. So wait for the next installment. Thank you very much and enjoy your weekend.